very excited to discuss the first disease state, hypertension. It is very likely that hypertension has affected at least one member of your family, so understanding hypertension pharmacotherapy is extremely important, especially because patients with hypertension are often asymptomatic. Let's dive right in. The clinically accepted guidelines are the 2017 ACC-AHA guideline for the prevention, detection, evaluation, and management of high blood pressure in adults. But please note that other guidelines such as JNC8 have been used in the past, yet this guideline is used most commonly and has been updated since it was published. Normal blood pressure is defined as a systolic blood pressure less than 120 millimeters mercury and a diastolic blood pressure less than 80 millimeters mercury. Elevated blood pressure is defined as a systolic blood pressure between 120 and 129 millimeters mercury and a diastolic blood pressure less than 80 millimeters mercury. Now we can move on to our definitions of hypertension. Stage 1 hypertension is defined as a systolic blood pressure between 130 and 139 millimeters mercury or a diastolic blood pressure of 80 to 89 millimeters mercury. Stage 2 hypertension is defined as a systolic blood pressure greater than 140 millimeters mercury or a diastolic blood pressure greater than 90 millimeters mercury. Finally, hypertensive urgency and hypertensive emergency indicate a systolic blood pressure greater than 180 millimeters mercury and or a diastolic blood pressure greater than 120 millimeters mercury. The major difference between the two is that in hypertensive emergency, target organ damage is present. We will discuss this in more detail toward the end of the video. The renin-angiotensin-aldosterone system, or RAS system, is central to understanding how blood pressure is maintained and how hypertension is treated. The RAS system begins in the kidneys where an enzyme called renin is secreted. Renin works to convert angiotensinogen to angiotensin 1. Then, angiotensin converting enzyme, or ACE, converts angiotensin 1 to angiotensin 2. After this, angiotensin 2 binds to the AT1 receptor, which causes vasoconstriction of blood vessels and subsequently increase in aldosterone by detection of stretched receptors. Through vasoconstriction of blood vessels, they become more narrow, which helps to maintain blood pressure when the body senses a drop in blood pressure. When aldosterone is increased, this further helps to maintain blood pressure by increasing sodium reabsorption. It is important to remember that water follows sodium, so when more sodium is reabsorbed, water will also be reabsorbed, so that there is more volume in the vasculature. When there is more fluid in the vasculature, blood pressure increases. We will revisit this concept as we talk about drug therapy. Another integral system that affects blood pressure is the sympathetic nervous system. When you think of the sympathetic nervous system, think of the fight or flight response. When the sympathetic nervous system is stimulated, norepinephrine, amongst other neurotransmitters, is released. Norepinephrine works peripherally to vasoconstrict blood vessels and increase total peripheral resistance, also known as systemic vascular response. Norepinephrine also works on the heart to increase heart rate and contractility of the heart. We have medications that can work on both of these two pathways. There are many factors that increase a person's risk of developing hypertension. These include increased age, poor diet, including a high sodium diet, and obesity, family history, especially if a first-degree relative has hypertension, and race. Specifically, the risk of developing hypertension is more common among people of African descent as they are more likely to have more resistant hypertension. Smoking, living a sedentary lifestyle, and drinking too much alcohol. As pharmacists, it is always important to look for drugs that can raise blood pressure. Stimulants are a major class of drugs that can increase blood pressure. This class includes ADHD medicines, including methylphenidate and amphetamine salts, cocaine, caffeine, one of my faves, and decongestants like phenylephrine and pseudoephedrine. Remember that sodium and water retention increases blood pressure, and there are drugs that do just that, including nonsteroidal anti-inflammatory drugs or NSAIDs like ibuprofen and naproxen, steroids, and immunosuppressants. The danger of hypertension is that it typically does not cause a patient to have symptoms. Thus, it is important that patients are aware of the complications of having uncontrolled hypertension. The heart can be damaged by dilation of the left ventricle. The patient can develop heart failure and even ischemic heart disease. Renal failure can result from prolonged damage to the kidneys, and the brain can be damaged as a result of hypertension causing a hemorrhagic or ischemic stroke. The most recent ACC/AHA guidelines made things really easy by setting the blood pressure goal for nearly all patients to less than 130 over 80 millimeters mercury, regardless of the patient's comorbidities. So, let's take a look at how we're going to reach this goal with current treatment. An integral part of treating hypertension is through non-pharmacologic therapy. Studies show that weight loss, sodium restriction to less than 1,500 milligrams per day, smoking cessation, exercising 30 minutes per day, at least 5 days per week, and following the DASH diet, which is the most impactful way to reduce blood pressure. This diet is rich in fruits, vegetables, whole grains, lean protein, and low-fat dairy. These foods are high in nutrients like potassium, calcium, protein, and fiber, which promote a reduction in blood pressure. Now, before we jump into drug therapy, it is important to properly assess our patient. The first thing we want to look at is, of course, whether or not the patient has hypertension, and if so, what stage. Next, we want to identify any pertinent comorbidities that may warrant pharmacologic treatment for hypertension, such as diabetes, clinical ASCVD, including coronary artery disease, myocardial infarction, stroke, and peripheral artery disease, as well as chronic kidney disease. Patients with diabetes and chronic kidney disease may benefit from blood pressure control, but we are going to focus on clinical ASCVD risk in this video. Finally, we want to look at a person's 10-year ASCVD risk score if they do not have clinical ASCVD. ACC/AHA has a 10-year ASCVD risk calculator that looks at gender, age, race, cholesterol, whether or not the patient has been on a statin, has hypertension, has a smoking history, and whether or not the patient has diabetes and/or is taking aspirin. We'll start with a patient with stage 1 hypertension. Remember, this is defined as a blood pressure of 130 to 139 over 80 to 89, with either clinical ASCVD or a 10-year ASCVD risk score of 10% or greater. We will go ahead and initiate an antihypertensive medicine in addition to lifestyle changes. Then we'll assess them again in 1 month to determine if a therapy change is needed. For a patient with stage 2 hypertension, defined as a blood pressure greater than 140 over 90, regardless of their ASCVD risk or status, we will initiate an antihypertensive medication in addition to lifestyle changes. We will also reassess them in 1 month. But how do we treat patients with elevated blood pressure or stage 1 hypertension without clinical ASCVD or with a 10-year risk score of less than 10%? For these patients, we will not start antihypertensive therapy. Instead, we will begin by encouraging lifestyle modifications, and we'll reassess them in 3 to 6 months. Now, let's discuss the drugs in detail. When we initiate treatment in a patient with hypertension, we will treat non-Black patients with either a thiazide, a dihydropyridine calcium channel blocker, an ACE inhibitor, or an angiotensin II receptor blocker, otherwise known as an ARB. For Black patients, we will initiate a thiazide or a dihydropyridine calcium channel blocker for better efficacy. In patients with chronic kidney disease, indicated by a GFR less than 60, regardless of race, an ACE inhibitor or an ARB is preferred. Similarly, in patients with diabetes with albuminuria or presence of albumin in the urine, an ACE inhibitor or an ARB is preferred, again, regardless of race. The nephron is a functional unit of the kidney and is a site of action for many antihypertensive medications. One class of medications, called thiazide diuretics, work at the distal convoluted tubule, and we will discuss these in more detail shortly. Another class of medications, called potassium-sparing diuretics, including spironolactone and eplerenone, work at both the distal convoluted tubule and the collecting duct, which is the final regulator of fluid and electrolyte balance. These medications are not first line for hypertension, so we will not be covering these medications in this video. Lastly, loop diuretics work in the thick ascending limb of the loop of Henle. These drugs, including furosemide, torsemide, and bumetanide, are excellent in promoting fluid loss from the body, particularly in cases of heart failure. However, these are less effective as antihypertensive agents as compared to thiazide diuretics due to their short duration of action. Now, let's take a closer look at thiazide diuretics. Thiazide diuretics, including hydrochlorothiazide, chlorthalidone, and metolazone, work by inhibiting sodium and water absorption in the distal convoluted tubule. Through their actions, they decrease electrolytes, including sodium, magnesium, and potassium, and can increase uric acid, blood glucose, triglycerides, LDL, and even calcium. Thus, we must use these cautiously in patients with acute gout attacks or patients with low bone density. Looking at the structure of hydrochlorothiazide, we can see sulfa moieties. Due to this, it is important to not recommend thiazides to patients with sulfa allergies. Because it is a diuretic, we want to encourage patients to take these medicines in the morning rather than later in the day to avoid having to urinate at night. Unlike loop diuretics, thiazides are ineffective in patients with severe renal impairment or with a creatinine clearance less than 30. Now, let's revisit the sympathetic nervous system's role on blood pressure to understand how calcium channel blockers work. Dihydropyridine calcium channel blockers work best as antihypertensive agents by preventing calcium ions from entering vascular smooth muscle cells, thereby decreasing total peripheral resistance and promoting dilation of blood vessels. Non-dihydropyridine calcium channel blockers can also work as antihypertensive, but work best in stable ischemic heart disease by decreasing oxygen demand by decreasing heart rate, or chronotropy, and the strength of the heart's contraction, or inotropy, by preventing calcium ions from entering vascular smooth muscle and contractile myocardial cells. We will focus on dihydropyridine calcium channel blockers as our primary antihypertensive calcium channel blockers. Examples of dihydropyridine calcium channel blockers include nifedipine and amlodipine, among others. Both clovidipine and nicardipine are IV options in this class. Of note, clovidipine comes as a lipid emulsion. Due to dilation of the vasculature, dihydropyridine calcium channel blockers can cause reflex tachycardia, headache, flushing, peripheral edema, and even gingival hyperplasia, which is swelling of the gums. Briefly, our non-dihydropyridine calcium channel blockers include diltiazem and verapamil. They cause similar side effects as our dihydropyridine calcium channel blockers, but verapamil is particularly known to cause constipation, which may be bothersome for a patient already experiencing hard stools. Both classes of calcium channel blockers have drug interactions with cytochrome P450 enzyme 3A4, but diltiazem and verapamil are potent and very strong inhibitors, whereas dihydropyridine calcium channel blockers, like amlodipine, are CYP3A4 substrates. As we revisit the RAS system, we can see where additional antihypertensive drug classes work. Direct renin inhibitor aliskiren inhibits the conversion of angiotensinogen to angiotensin 1. ACE inhibitors inhibit the conversion of angiotensin 1 to angiotensin 2, and ARBs inhibit the binding of angiotensin 2 to its receptor AT1. Finally, aldosterone receptor antagonists like spironolactone and eplerenone, as mentioned earlier, can block the effects of aldosterone. Our two main staples in hypertension here are ACE inhibitors and ARBs. ACE inhibitors can easily be identified with the suffix -pril. ARBs, on the other hand, often end in sartan. Their actions on the RAS system potentiate vasodilation of the efferent arteriole within the glomerulus of the kidney to decrease the filtration rate and workload of the nephron. A key adverse effect to know is that ACE inhibitors can cause a severe reaction called angioedema. Patients with this present with a swollen face, lips, and tongue. This is a medical emergency, and it can cause blockage of airflow. This is caused by an increase in bradykinin that results from an off-target effect of the angiotensin-converting enzyme blockade. This adverse effect is more common in Black patients. When patients experience this, the patient should not be retried on either an ACE inhibitor or an ARB. However, if a patient experiences a dry cough from an ACE inhibitor, they can be switched to an ARB. Though there are other drug interactions with ACE inhibitors, they certainly should not be used with NSAIDs, as this can cause damage to the kidney. In pregnant patients with hypertension, we have to avoid some of our commonly prescribed antihypertensives. For these patients, we can initiate methyldopa, nifedipine extended release, or labetalol. But we must be sure to avoid ACE inhibitors, ARBs, and direct renin inhibitors like aliskiren, so that mom can have a nice, healthy baby. Finally, it is important to distinguish hypertensive urgency versus hypertensive emergency. As mentioned previously, both hypertensive urgency and hypertensive emergency occur when systolic blood pressure is greater than 180 millimeters mercury and or the diastolic blood pressure is greater than 120 millimeters mercury. Again, the major difference is that in hypertensive emergency, there is target organ damage in the kidneys, brain, heart, and or the eyes. For hypertensive urgency, we can treat patients acutely with hydralazine, labetalol, or clonidine. All of these medications can help to vasodilate blood vessels and reduce blood pressure. In hypertensive emergency, we can use IV antihypertensive medications to reduce blood pressure. This must be done carefully in order to prevent further damage to organs by reducing the patient's blood pressure too rapidly. You guys made it! Thanks so much for tuning in, and I hope you learned lots about hypertension today. Please feel free to subscribe and comment. I'm happy to take any questions and also learn with you guys. Thanks so much, and take care.